I'd like to go for, can we then go for the, yeah, we do a PRK, for example, with manifest, let's take plus 0.25 minus 0.5 at 75 degrees. That's about it. Yeah, no, plus 0.25 sphere and minus 0.5 at 75. I'm taking just the wavefront, the approximation within the 4 millimeters from the Zernike refraction. Okay. Okay. And now I would like to go into the manager. And here you can easily now take off selectively which aberrations you would like to correct. We saw before that we have a severe problem in spherical aberration. We also do have coma because it was descentered, and those are the two main high order aberrations. So you can selectively go in and say, yes, I would take off the trefoil, not interested in. I take the quatrefoil. I just want to do that what is really important. So that take the coma, second order, but take the trefoil again out. And that's what we call selective. That's what we call selective wavefront guided treatment. So you correct only, and we don't need that one at all. Everything is green here. Here is green. Then here we just do that is the coma of second order. So we are correcting only those aberrations that make the vision bad. And unfortunately, if you do a Scheimpflug camera, Scheimpflug photograph driven topographic treatment, you cannot monitor how the point spread function is changing. However, the wavefront guided treatment you can. So we deselected now those 7 aberrations to be a minimum corrected, and now we apply that, and you see we had 55 microns at the maximum here before, and if you apply that, it's getting even more a little bit there because we took off some compensations out in that area. So here we are. That is the treatment I would recommend in this case, based on refraction and based on the wavefront analysis.
So, Theo, I have a question for you.
Sorry?
I was going to ask you to do what you just did, and that is to compare the ablation depth with your selective treatment versus a more global treatment. In light of the fact that you actually are now having a slightly deeper ablation, what is the negative of the more global treatment?
The deeper ablation, 2 microns.
I know, it's minor, but that's...
Sorry?
It's not significant, I understand
Most
that.
probably it's not a big deal anyway. So,
right.
But nevertheless, this is because some of the coma of 3rd order, of 4th order will compensate at that point up there to make it more precise. And if you skip that, then you may have an increase in depth, but maybe the total volume has not changed that much.
But from a clinical, and we may not have the answer, from a patient point of view, the outcome point of view, what is the difference if effectively the ablation depth is similar between a selective treatment that you've done here or a more global treatment where you don't exclude the other aberrations?
In this case, you need to enlarge the optical zone, isn't it? That patient was completely... Maybe
well, the question is if you don't take it off, keep all of them.
Yeah.
If you don't take it off, keep
Yeah.
all of them in.
Yeah.
And if you come back more, you get
Oh yeah, you are right. I mean, in this case, you don't have to select it. I rather would go for everything.
Right. So
In
I
a
think
practical sense.
it's great that
That's
you
okay.
can look at.
Yeah.
The other
we wanted to,
comment-
but we wanted to learn how to select
I
aberrations to be
understand
treated.
that. The other is only a defense of the U.S. There was never an optical zone smaller than 6.0 approved in the US. So if you have a decentered ablation, it will often look like a smaller optical zone, but I'm guessing unless she was in a black box treatment in the US, that her original optical zone was at least 6.
This was done in 80s, early
But
80s.
then it was a black box.
Yeah, maybe.
Okay.
Okay. You know, I remember that if that was in 25 years ago, if that was indeed a summit, remember we started with a 4.5 millimeter optical zone, went up
But
to
not in
5.
the US.
In the US it was, I was senior medical
I know,
monitor
I
for
know.
that study, and it was 5 millimeters at minimum in some of the cases to be treated.
But not approved, that's correct. And I was the
Oh, it might be
FDA, I
not
was the
approved,
reviewer.
but,
I was the
yeah.
primary reviewer for that.
Yeah.
And you
Oh,
had data like
nevertheless,
that.
I mean, it was a mistake to make those small areas.
Yeah.
That's for sure.
Can continue?
I'm done right now, but I would say in this case, I rather would have gone for an ocular wavefront. So to take the in a 65-year-old lady, I rather would take a decentration of the lens also into account, and that's where I'm coming back to that centration of lens stuff. Sometimes, if you do a LASIK after multifocals or even after aspheric ablations, you recognize if you do a wavefront analysis that you do have a hell of a coma. And the cornea looks nice, and the coma obviously occurs because the lens is slightly descended, not obviously descended, but descended to the chief ray, to the optic axis. And that's why, to make that long story short, I gave up in centration all these lenses because even if you do have a constriction of the anterior capsule, the lens may shift in 2 or 3 years a little bit. If that is a problem, I rather go to the cornea, do then an ocular wavefront guided treatment to get rid of those side effects.
But you
Yes,
said
in
ocular wavefront guided treatment in a 50-year-old patient
65-year-old,
with
right?
55 will also have a lenticular aberrations. So how
That is for sure. And
she has a cataract? Yeah.
But she had cataract surgery
Yeah.
before.
No, she has a cataract.
She has a
Oh,
cataract.
she had a
so
cataract.
She has
She has a
cataract.
I mean,
cataract,
then
so
it
you-
was a fault anyway to treat that
Yes.
eye. So you should not treat that eye with a laser if she has a cataract, period. Maybe the spherical aberration was even, the cataract may have compensated parts of the spherical aberration induced by the cornea, or vice versa, and then you make it worse.
No, but my question is, would you want to regularize this cornea before doing the cataract surgery? And if you want to regularize the cornea, then you would like to do a topolink treatment rather than a wavefront, ocular wavefront, because with an ocular wavefront, you're correcting the aberrations in the lens. Which you're going to
Yeah.
remove later on, and you're going to leave a lot on the cornea. So typically it will be worse after the cataract surgery, right?
No, I tell you, just in earlier times, I always made the zone larger, and then you could calculate the IOL much better because you didn't have to interpolate the K readings, which are different at different distances from the center. And so I enlarged the optical zone first and did then the cataract surgery. But that was not very successful in terms of the patient's expectations. You did then a treatment, and the patient had to wait for half a year until you get a nice optical, and during that time he didn't see well, or she didn't see well. So we started with the cataract first, and did then the orthogonalization
So in this
and
case,
regularization.
you would prefer to do a cataract surgery first,
I would do the
and
cataract
probably
surgery.
leave the patient a little myopic, so you can do a myopic correction.
Yeah, for example. Or in this case, a hyperopia would be even a little bit of hyperopia plus 0.75 would be even better because you have to remove some tissue from the mid-periphery, which does a hyperopia correction. So in essence, I would plan, if I can calculate the lens, I would aim on plus 0.75 and do then later on away from guided.
But a hyperopic treatment would induce more aberrations, right?
Sorry?
A hyperopic treatment would induce more aberrations and would be less predictable in
But
terms of correcting the topography.
But don't forget, in the central area, the cornea is the thinnest, and therefore you never go a risk for doing something wrong if you do a hyperopia correction in terms of keratectasia or irregularity. And in this case, you would normalize the mid-peripheral cornea by a hyperopia correction. I mean, this was a pathological shape of the cornea, and you would regularize it if you would do a hyperopia correction.
This is a right eye, and same lady. For this eye, we did a regularization of cornea on this one, the topolizer, and then did a cataract surgery, and she is 6'9", and with the 0.25 post cataract surgery, that's her vision, but she's not very happy with the quality of vision because she's got a scar. So can we run the program on the topolizer, how you would do for this one?
Rohit, is this a decentered ablation or is it superior keratoconus, superior ectasia? Because
decentered, because
you have that 49 diopters, focal steepening in the superior area.
But you know, she's been on a very, very good follow-up with multiple places. She has got Pentacam from 2003, 2004.
And it's been the same.
It's been the same. And there's been a huge epithelial changes out there also. And she's got a very loose lids, not like an entropion, but it's not a very healthy lids. So something must be happening out there. So
why not do a cataract surgery first and then subsequently?
I mean, like
because
he said,
you never know the outcome of what kind of aberrations are going to be left behind. Aim at a mild myopic result, and then 3 months later.
The challenge of any topo-guided treatment is that you don't know how much of. I'll just show it here. You can see the amount of ablation. Once he plugs this in on that screen, it's already there, right? If you just make it 0, then you'll probably get it.
So, yeah, we always start, in those complicated cases, we always start with a 0 refractive change just to get a feeling what is wrong with that cornea. And you may see that we do get what we expected. Here, at that area, we wanted to do a hyperopia correction. We wanted to steepen up that flat zone. Do we have a pointer here?
You can come
no,
here.
That one, but that over there. Okay, whatever. I'm just running over, showing you. So, don't trust the software at all. You always have to make your own opinion. What do we expect in order to make that cornea working more or less? So if I'm going to the sagittal curve, I would rather do a hyperopia correction in the inferior part because that is too flat. So I'm expecting to have a banana-shaped ablation in the inferior part, and that's what we are seeing there. Okay, we'll have that. But even if you steepen that the inferior part, you still have an undercorrection in the inferior part. So you need to flatten that 49 diopter correction. So you do a myopic correction in the superior part, and that's what we are seeing here too. You see again there we do have that in the upper area. Here. In that upper area, we do have a kind of myopia correction, flattening that area. Now, I trust that ablation pattern now because it fulfills my expectations. And then I will have to talk about the size of the ablation zone. If you do have a hyperopia correction, how much is it now? 6.5. I think in order to save tissue, I would not go to a higher optical zone, but let's try how it would work out if you go for 7 millimeters, which is typical for hyperopia correction. So we increase the maximal ablation depth from 33 to 42, which in a 60-year-old lady we still can afford. If that would be a 23-year-old lady, we would leave your fingers off anyway. But that is a hard and a very stiff cornea.
Can you just, I would like to answer Dr. Ramurthy's question here. You are seeing a peripheral ablation of 40 and the center of 13. So imagine you have put an IOL of this and you're doing this ablation, keeping everything as 0, assuming everything as 0, you still would be with a -2 diopters.
Still, we have not talked about the refractive change so far.
So
This
you
just
are-
to regularize
so
the
you have
cornea.
to go for a hyperopic overcorrection because the patient would end up in a myopic shift.
No, because the thing
And
is,
if-
because we have the advantage of doing a cataract surgery following the treatment, so even if doesn't matter what the refractive change is, still when we choose the IOL, after maybe 6 months of stability,
My problem is the acoustics is so bad, I have to come closer.
yeah. So since we have the advantage of IOL planning following the treatment,
Yeah.
so doesn't matter what the refractive change is, still we can always correct it with the IOL.
I agree. So if we do this prior to cataract surgery, we just would do the minimal thing we can do, and the rest will be compensated by the lens, of course.
So, and would you like to do a compensation here?
What?
The Zernike compensation here? C4, C12?
Oh, in this case, I think it's not necessary. That includes, as Michael mentioned, that includes all Zernike approximation up to the 8th order, and I have no good reason to save some of those in this.
Rohit, it would work the other way around also. So whatever is induced cylinder or refractive error post-cataract can also be removed when you do a topoling.
I mean, there is both way because, I mean, we were looking at that kind of a cornea in a lady who has a scar from CNVM. So their line of sight, what it's hitting the macula, whatever little macula remains, it was not right. So her scatter, glare, and also was dependent on her cornea and also from her macular issue.
The problem is the axis of the astigmatism here. The cylinder is almost the opposite way. So what would you treat?
Most probably that lady was not using that eye for many years, because she did in the other eye so much better, so that the dominance has changed.
No, he's asking,
No.
the cylinder of acceptance is 105.
Yeah.
The topolizer is 161, which is opposite of that.
I think-
Which one would you treat
No.
when you're planning?
No, actually, because patient is a cataract patient, I mean, you shouldn't rely too much on refraction part.
No, but if
if-
there was a real case without,
Yeah, if we
because
have
it happens a lot in those
Yeah,
cases.
so if we have a history of her before she developed cataract refraction, okay,
So-
maybe some kind
No,
of.
but
a
suppose there's no cataract. My point is many clinicians like me and others in the room are facing these things when you have a decentration. That's illustrating what I was saying this morning. The refraction is made with the high order aberration, so the patient chooses subjectively a cylinder with the coma and the trefoil and everything. But if you correct them on the cornea, then probably that would change, and then this astigmatism will show the second one. So
Which
No, no,
one would you
this
treat?
is-
The 161 or 105?
if I do custom treatment, I use the second one, not the refraction one, because in the refraction one, you have the effect of the coma and everything you remove. So ideally, what you should be able to do when it's difficult is to have like a adaptive optic bench where you would remove the high order aberration optically and refract the patient, find the sphere and cylinder, and go to the laser, enter that sphere and cylinder and the high order aberration.
And the problem is that a cylindric glass can compensate parts of the coma.
That's what I'm saying.
Yeah, that was Mrs. Marcos. Susan Marcos made a very nice paper on that a few years ago, that you could correct 45% of the waveform of the coma with cylindric glasses, and that's what we are doing every
Yeah,
day.
it's
Wait,
one
wait,
of the
wait, wait,
best
let
papers.
me finish. We are doing this every day. If a patient comes in with a plain keratoconus, simple keratoconus, he doesn't have astigmatism at all. He has coma only, and he is running around with cylindric glasses. So we know this already, but we never, and therefore I agree, we should leave your fingers of the refractive cylinder, because that is for sure wrong.
Yeah, the paper is very nice, one of the best I've read in this topic. And the point is, it's not intuitive. You would believe that, okay, if you have vertical coma, I will have a compensation with against the rural astigmatism. But the best compensation occurs for, you remember that, 35 degrees sometimes. So if you have a coma vertical, it's when the cylinder that you rotate 35 degrees from the coma, that cylinder will provide the best subjective compensation for the coma. So it's quite difficult, but usually against the rural astigmatism arises with vertical decentration, superior or inferior, and you can understand that because, forget of the map, but it's like a flat slope in the center, and the steepening is more in the periphery of the cornea. So that's why patients, they like this against the rule in their spectacles.
We have to point out that this is the best guess. That patient may have still have had an astigmatism against the rule before the surgery, and you will miss that. Michael?
Yeah, I'm going to ask, can someone go up to the, or else use a pointer, the upper right picture on the pentagram, someone outline what they think is the optical zone of that treatment?
What was the optical zone for, he said 7 millimeter.
No, I'm not saying what it says. On that, just use a pointer or someone go up and with their hand and just point out where they think, that's the front elevation map, the upper right, where they think the optical zone is.
That zone?
Okay, so that would be the common answer people would give, that green area, correct? Yeah,
That's his optical zone of that.
I'm not even sure about that. You know,
so
I think it would be a little bit bigger.
It's substantially bigger.
Yeah.
And that's because if you, again, that's going against a reference surface taken from an 8 millimeter zone of the cornea, which is obviously larger than the treatment zone. When you flatten the cornea, you're going to then flatten the reference surface. When you then fit it as a float, you actually intersect in the middle of the optical zone, not the middle of mid-periphery. Yeah. So that green zone is a transition between the reference surface, is not the end of the optical zone. So it looks like a small optical zone, it's really not. I will try to draw this more schematically and show it tomorrow. But you can't look at that and kind of determine where the optical zone is.
And I mean, remember that we started with that topography guided treatment. Hey, I think that's why when we started with that topography guided treatments 50 years ago, we learned the hard way that topography guided treatments in about 50 to 60% are a two-step procedure. You do it once, and you have to do a fine-tuning, in most of the cases, a refractive fine-tuning later on, because you missed a lot of things. You missed the astigmatism, you missed sometimes some spherical aberration, because those, also you miss the healing, of course, and the expectation of the patients, by the way.
Rohit, just an idea. I was just thinking, can you use this ablation map pattern and do a 3D printing of a contact lens and put it on the patient, just like how you make a cast. This is the mold, so you make a cast with a 3D printing, because now you have 3D printing technology, and then you can actually put it on the patient and see how much the vision improves before actually treating the cornea and removing tissue.
If you do the 3D there, it's already there.
Yeah.
Put the 3D there. There's after Zernicke, there's a 3D.
So you can use this to actually do a 3D print of a contact lens, put it on the patient, and see how much it improves the vision.
If you can turn that around also.
Yep.
She was wearing a hard contact lens.
No, a hard contact lens is different because there it's the tear film. But if you can make a 3D print of a soft
I think
lens
Chandrasekhar Chavan is doing it. What he does is he has a mold, and he uses the mold on your cornea, and he takes that mold and he gets it 3D printed, and I've done it for one patient who had a very, very irregular cornea, and it's not from here, but he actually puts the mold on the eye, some kind of a, I think it's the mold impression of the cornea, exact impression of the shape of the cornea, he 3D print. And I have given it for one patient. It takes a long time.
But can you use this to do a 3D print is what I was
This is an ablation, I don't know. He says, can you 3D print this and make a contact lens?
That one not. We did the impression stuff with silicone and cross-linked the silicone, and then went to Falco, and they prepared special back cervical contact lenses, and we made actually a EU project out of that, which failed after all. I'm sorry for that, but patients could not use it, and it was rotating all the time. So unfortunately, in this case, maybe it would not.
Have you treated this patient?
It would not rotate, but in our normal, of those patients, it just didn't work out.
This is what we did. This is the treatment outcome. You can see the difference map.
Yeah.
And the center one is the treated one. And you can see that the machine, it was done on the topolizer. And you can see that the green one is exactly the area the machine made it hyperope.
Yeah.
And after this, this was used for post-cataract,
And what did you do then?
surgery.
You did then cataract surgery?
Yeah.
Okay, that's okay.
And
So if you would have done cataract surgery before, and this turned out to be hyperopic +2, what would you have done then?
That's the challenge. That's what, this ended up with more regularization. I felt that this had a better chance of an IOL calculation.
Oh, I do so.
You can see that it's became more regular. In fact, after this, she became much better in terms of her glare, because I think the light started going properly into where it should be, because she had no good macula.
No good macula.
Yeah.
Another question is, now you have the technology of light adjustable lenses. So can you use light adjustable lenses for irregular corneas like that, and modify the lens to compensate for the cornea so that the total wavefront is actually good and the vision is good?
I was very early on involved in that light adjustable lens stuff, and I turned around and went back from that project after about 2.5 years, because you could correct only spherical aberration and a little bit of astigmatism and sphere. And when I asked them just to correct also higher aberrations, at that time the company was not liquid enough to invest more money in that algorithm. I fully agree with light adjustable lenses, especially of the new generation, that could have been done post-operatively also. But whenever you do that, you do have some limits. They cannot, it's cross-linking that they're inducing, and that is a little bit less predictable than other things.
I think we'll break for coffee, and after that we'll come back, and Dr. Sujata has 2 cases, and then we'll discuss some few cases after.
Why you didn't do the cataract first and followed by the...
I thought that optically,
Suppose you had left the cornea without any treatment, what would have happened?
we've had cases in the past where, patients who had operated on this had different significant errors of glare or being unhappy with multiple things. So I thought, why not make it more regular like that? The cornea looks very regular. I think Naren is going to show it tomorrow. I think that
Which formula and how do you calculate the IUL after you correct the cornea is also very important.
Yeah, I think I saw her just a week back. She came for the other eye. We have not done the cataract yet. But I just saw a refraction of this. It was 6.9. Uncorrected. And a minus 0.5, minus 0.25 or 0.5 was the refraction. I remember, because the other eye, she's still, she needs a surgery.
Because you have refractive surgery, and after that you have a correction.
Two surgeries.
Yeah, 2 surgeries, hyperopia also, and then a myopic kind of a thing. So.
But I feel that if you have more regular shape like this, the IOL calculation.
Yeah, regular shape is better, but I think probably you'll have to use total keratometry and.
I think you are having that tomorrow, no? He's going to show
because the Gulf-Strands ratio will be totally altered, so you can't use the normal one.
Basically, we have a more of an open discussion session tomorrow. I think let's all discuss about the same tomorrow.